Our last talk for this session is by Dr. Andrea Natali from St. David's in Austin, and he'll be talking about left atrial appendage exclusion for stroke prophylaxis, state of the art of the field. Andrea.
Thank you. Thank you. So some of this information has been already discussed by the previous presenter. I think one of the sort of additional comment I want to make is that not only atrial fibrillation increases the risk of stroke, but a stroke with atrial fibrillation are stroke that lead to a higher risk of mortality. So they are not benign things most of the time. They are certainly more likely to lead to either death or severe impairment more than stroke related to thrombotic disease. I think what we believe is that at least in patients with atrial fibrillation, certainly in patients with atrial fibrillation, the majority of thromboembolic event related to the formation of clot into the left atrial appendage. And this is something that has important implication in what we're going to talk about in the next few minutes. The left atrial appendage is a remnant, is a gestational remnant that have a variety of shape and size. Here I put 10 to 40, but actually we have seen patients that have a left atrial opening bigger than 40. It's probably less than 2% of the population, but you see some once in a while patients with really giant appendage. And obviously the thickness and of the wall and the shape and the direction is different in everybody. There is an increase in literature now that really look at the shape of the appendage, mostly because of the therapeutic option that we have today, but also because that could have implication even in terms of risk of thromboembolic event. You heard that Coumadin certainly has been established as an effective treatment, and as you heard from the previous presentation, even some of the newer anticoagulant. However, one of the problems with these drugs is that you need to take them to actually be able to help you in preventing the risk of this dismal and serious complication. And when you look at the literature addressing the compliance to patient, this is one of the studies showing that over a few months, nearly 18% of the patients discontinue Coumadin. And when you look at patients that are still taking the drugs but they are not compliant, this number can go up to 40%. And the same is true for the newer anticoagulants. They might be more convenient, certainly to take in terms of lifestyle, and for some of them even more effective and coming with less risk of bleeding complication. But even these drugs, they lead to higher rate of, they are associated with higher rate of discontinuation because of side effect and several other reasons. And with this medication, even more, this is even more important than with Coumadin, where missing a dose is not a big deal, whereas with this medication, missing a dose can lead certainly to a very quick situation of being unprotected. So this is where non-pharmacologic treatment of stroke prevention can sort of become maybe an alternative strategy, and maybe, who knows, in the future, the preferred strategy for some of the patients, as long as insurance will pay for it. So let's look at the mechanical. Right now, in the US guidelines, this is not even mentioned. In the European guideline of 2012, actually, this is listed as a potential option, both surgical and the mechanical device that we'll mention. There are two approaches to this, to mechanical occlusion of the appendage, one endovascular and the other one is epicardial. And with the epicardial, probably most of the devices you're familiar with are surgical device, but there are actually percutaneous options that I'll mention, which are now becoming more popular. With the endovascular device, the PROTECT AF was the first randomized trial which prove non-inferiority of this approach, and also in a way prove the concept that in the majority of this patient thromboembolic event originate from the appendage, because this was the target organ for the mechanical approach, after which a significant number of patients, the majority of patients, discontinue anticoagulation. This is an example of a patient, a 1-year follow-up that shows sort of a CT scan demonstrating complete and permanent occlusion and a good outcome in this patient. When you look at this is data from the AF at the economic analysis of a variety of approach, LA closure, despite is perceived as an expensive approach, actually can be more cost-effective over time, certainly when compared to some of the newer anticoagulants. This is the device that was used in the AF, is called the WATCHMAN, come in size, and this is a limitation that the maximum size now is 33 millimeter, and as I mentioned, the appendage size, the ostium, can be as big as 40 millimeter in the majority of patients. There are a fewer percentage of patients with even bigger. Consider that when you size the device, you have to size the device with about 20% bigger dimension because you are stretching the tissue. So if you use a device of the same size of the appendage that you measure on a CT, on an echo, you will have probably a lot of dislodgement. So this is something to keep in mind. Is implanted, is a completely endovascular approach to a transeptal access. And this device has been approved in Europe in 2005, hopefully soon in US. This is the way this is two example in a canine model and also in a patient that die for other reasons, showing a sort of a smooth surface covering the device, which sort of explain why this device is effective in preventing thromboembolic event originating from the left atrial appendage. This is a busy table showing all the study, the data that has been produced by using the WATCHMAN, the PROTECT AF that I showed you before. Then the registry, the CAP study that was a registry that followed the end of the PROTECT AF. The ASAP registry, there was a study without randomization for patients that were unsuitable for Coumadin. They were assigned to the device, followed by 6 months of clopidogrel and then aspirin only for the rest of their life. And then the PREVAIL that is designed similar to the PROTECT AF randomized study. They were just concluded, and I'll show you some data that was done for two reasons. One, there was a concern from the PROTECT AF that there was an increased risk of acute complication with the implantation of the device, and also the FDA wanted to have data on higher risk patient. The inclusion criteria of the PROTECT AF was CHAD score equal or higher to 1, whereas in the PREVAIL was a CHAD score equal or higher than 2. So this is to show some clinical effect from the PROTECT AF study, actually including also showing the result with Coumadin. So you see in warfarin and in purple the WATCHMAN, ischemic stroke, all stroke, ischemic stroke, hemorrhagic stroke, and then systemic embolism and cardiovascular unexplained death. And you see that overall there was no significant difference. There was a trend towards better outcome with hemorrhagic stroke, with the WATCHMAN, and also the cardiovascular unexplained death was lower with the WATCHMAN than with the Coumadin. But in terms of all ischemic stroke, there was virtually no difference. The slight increase that you see there, one contribution was the peri-procedural stroke, and we'll talk a little bit about that. So here again, and actually here, this gives you an idea of the impact of the peri-procedural stroke that you see here. So if in the picture on your left, you see the risk of ischemic stroke over time, and you see at the time of the procedure, obviously, there is no risk on Coumadin in purple, whereas there is some risk with the WATCHMAN, and then from 1 to 45 days was similar, and also beyond 45 days. And obviously, as I showed you before, the risk of hemorrhagic stroke was higher with Coumadin, as you expect. The primary efficacy in patients with previous stroke was also show a benefit from the WATCHMAN. Although this was not sort of this is a sort of a after the fact analysis, so we have to be careful about the meaning of this information. And when you look at procedure outcome in the WATCHMAN patient as compared to the early experience versus the late experience, and the CAP, the registry, which was the patient that were assigned to the WATCHMAN once the protective AF was done, you clearly see that there is a learning curve. And this is something that will sort of remain through when I show the data from the previous study. So clearly, this is a invasive procedure. As with any invasive procedure, there is a learning curve that has many different sort of aspects, from the experience with the transeptal access, the experience in dealing with the left atrial anatomy, and the fact that this is a mechanical device that to be deployed into the appendage. There are devices now that are being designed, there are features that are unique, that might contribute to a reduction of the risk of bleeding by the fact that they do not have to be deployed at the tip of the appendage, which could be a reason for some of the bleeding complication, the tamponade that occur with the procedure. Again, here, some data in patients older than 75, where you see the primary efficacy showing some benefit with the WATCHMAN. Again, all stroke and all-cause mortality was similar. Major bleeding, again, in this population, you have some acute risk, as you expect, as I mentioned before, during the device implantation, but then at follow-up, obviously, the risk was lower with the WATCHMAN. And this is the registry, the CAP study that I mentioned before, showing that the risk of this complication sort of was lower once the operator sort of gained enough experience. Pericardial effusion, again, show a trend, a clear reduction between the early experience and the late experience, and obviously in the CAP study, this number settled to a lower number. So certainly there is a risk, but the risk sort of dropped with the experience of the operator. And a safety event, again, show a sort of learning curve effect from, as you see here, from the protected AF and the CCAP study. This is very true with the stroke-related procedure. I think consider this is a device that is deployed to a 14 French introducer, so an air embolism can be significant. So learning how to deal with every aspect of the procedure after operator gain experience are certainly responsible for the significant difference of both bleeding and stroke complication that you see here between the PROTECT AF and the CAP registry. This is our data that have been recently published showing the outcome at 2.3 years. Again, this is the result from the PROTECT AF, and this is the outcome at the landmark study showing that there is a continuous benefit from the closure device, the efficacy doesn't disappear over time. And this is from the registry that I mentioned before in patient that could not take oral anticoagulants. This is a group of 150 patients with a average CHA score of 2.8 that were, by study design, assigned to complete for 6 months and then aspirin for the rest of their life. And considering the expected stroke rate based on the CHA score, there was a 77% reduction from a 7.3 expected rate of stroke in this population. The observed stroke rate was 1.7%. And this is the PREVAIL. Again, as I mentioned before, the concern with the AF was a high initial rate of pericardial effusion and procedural related strokes. And I show you already from the CAP, the registry, that there was clearly a significant reduction. And other things that I didn't show is that usually the periprocedural stroke had a lower impact in terms of functional status and quality of life than the stroke the patient experienced at follow-up or the stroke the patient in the warfarin arm experience. So those periprocedural stroke are usually smaller stroke, but it's still a significant event in the patient life. And then obviously something that I don't mention here, there was the FDA wanted to have data on a higher risk population. The main point is acute 7-day occurrence of death, ischemic stroke, systemic embolism, and procedure or device-related complication requiring major cardiovascular or endovascular intervention, and then comparison on composite of the composite of stroke, systemic embolism, cardiovascular, and unexpected death, and then 8 months a comparison of ischemic stroke and systemic embolism occurring more than 7 days after the randomization. So this is the number of patients that were enrolled. Some of them were considered roll-in. There are cases that were not used in the final analysis, that they are part of sort of what was required, especially to the new operator, as part of the learning curve. And then of the 407 patients that were actually entered the randomization process, 2-to-1 randomization, so 269 in the WATCHMAN, 138 in the warfarin, and 4 did not undergo the implant, although in the final analysis were still assigned to the WATCHMAN. And of the 1 undergoing implant, 252, so more than 90% actually received were able to receive the device. And this gives you an idea of some of the demographic between the PROTECT-AF, PREVAIL, and the CCAP. The major really difference are the CHA score, as you expected, because remember CHA 2 was the minimum required, so the CHA score in the PREVAIL was almost 2.8, whereas it was much lower in the PROTECT-AF, it was 2.2. The PREVAIL was very similar to the CAP, the registry. And then there was a higher prevalence of patients with diabetes and previous history of stroke in the PREVAIL as compared to the PROTECT-AF. Procedural implant, you see this sort of stable rate of successful implant around 95%, which was higher than the PROTECT-AF. And remember, the PROTECT-AF, the rate was affected by the early learning curve, so as the complication rate. And here you have vascular complication. You see the PROTECT-AF in orange, and then the CAP, the registry, and the PREVAIL, they're very similar. And I'll show you some data. The PREVAIL obviously have the operator of the PROTECT-AF, so there are people that already went through their learning curve, but there was a group of newer operator. Remember, in this study, they went through a roll-in number of cases, but they also probably benefit from the experience of the PROTECT-AF in avoiding some of the issue that led to complication in the initial randomized study. Pericardial effusion, again, much lower rate in the PREVAIL than the PROTECT-AF, very similar to the CAP registry, And the same is true for effusion with cardiac tamponade requiring pericardiocentesis. And here you see the implant success between the patient that are experienced versus the new operator. So there was a slightly lower successful implantation, but overall this number is not significant, is not really huge. The secondary endpoint was met in the study, and the one thing that I wanted to mention that you will, I don't know if you've seen it already, in the event rate in PREVAIL in the patient on coumarin was much lower than the one of the PROTECT AF and in some of the other studies that Sana mentioned. And probably this is, although this was a relatively high risk group with a CHUD score of about 2.6, 2.8, the follow-up is a small number of patients, and the follow-up of this data is relatively short, much shorter than the PROTECT AF and some of the other studies, so that could sort of account for that. The acute 7 days occurrence of death, ischemic stroke, systemic embolus, and device-related complication, major cardiovascular, were all within the range, below the range, the upper confidence limit predicted study. So actually this endpoint was met. There was certainly in PREVAIL an improved implant success as compared to PROTECT AF, as I showed before. Increased composite vascular complication, the procedural stroke rate, and decreased perforation, and little difference in outcome between new versus experienced operators. So overall, many of these endpoints were met. And so in conclusion, despite implantation in higher risk of patient, the WATCHMAN device could be placed safely even by newer operator. And 2 of the 3 primary endpoints were met even in the presence of sort of a group that was higher risk. So I think between the PROTECT AF, the CAP registry, and the PREVAIL, I think it's fair to say that the WATCHMAN represent an alternative to oral anticoagulation for patients that have atrial fibrillation and non-valvular atrial fibrillation in preventing the risk of embolic event. There are some issues with this device beyond the acute complication we discussed by looking at the data of PROTECT AF and PREVAIL, and some of them are leaking. This is obviously an example of a good occlusion, but this is an example of a patient that got a device and have a leak. And leaking, the size of the leak can be different. Overall, our follow-up, when you look grossly at the outcome in patients that have no leak versus residual leak, the WATCHMAN still provide benefit in reduction of thromboembolic events. So the presence of, especially a small leak, does not appear to be something that affect the clinical outcome. This is similar to what we've seen in our experience, where we have only 1 patient with an existing leak, which usually is present anywhere between 15 to 20% of the patients. So it's not a trivial issue. We see it quite a bit. And in fact, some of the latest iteration of the device have been redesigned to minimize this sort of potential issue. So in this, in our experience, those are mostly patients enrolled in the PROTECT AF. We have only 1 patient with leak that experienced a stroke. And interestingly, in this patient, obviously this is anecdotal because there's only 1 case. The size of the leak, instead of remaining stable or getting smaller over time, tend to get bigger. And this is a patient that experienced stroke. The one thing that is under-recognized that we report in this series is this sort of soft thrombus right in the center of the device that was seen in this case at 12 months follow-up. because the caring cardiology of this patient decide to do a TE to cardiovert the patient. And so now in our center, we re-TE everybody 1 year. And this is something that probably has to do with the presence of the hook at the center of the device can remain uncovered in some of the patient. And it was probably responsible for this centrally connected soft thrombus, which dissolved once the patient was placed back on anticoagulants. The device has been redesigned to address this issue, so hopefully this is going to be something that belongs to the past, but I think we need to be aware of and maybe watch these people a little longer to maintain safety. So some of the issue with the endocardial device are incomplete closure, as I mentioned, but for the most part, incomplete closure seems to be less relevant. I think, we had this sort of an anecdotal case, so maybe it's worthwhile to relook at this small leaking, and if they remain small and stable, then probably safe to discontinue anticoagulation. There is this issue of thrombus formation at the size of the connecting hook that I think is going to probably be resolved by the newer device, but this is something that I think we need to monitor. And one of the major limitations is the inability to retrieve the device if the deployment is suboptimal, and the newer version of the device actually is going to be retrievable, as some of the other devices that are being tested in clinical trial. Some of the people, I want to show you the slides because this is something that we struggle a lot with surgeon. Obviously, closing the appendage is something that has been done by surgeon for many, many years. But the surgeon always thought that once they close, that's the end of the story, and we've learned that that's not the case. Certainly it's not the case when the ligation is performed with staple, as you see here. Most of the time, the closure is incomplete. Actually, in this review, the literature is almost 100% of the time when staple are used, there is some degree of reopening. When the appendage is ligated with suture, anywhere between 23 to 40%, if you look at follow-up with TE, you see some pouch. The best thing is to remove the appendage. The surgeon don't like to do that because it increases the risk of bleeding, a follow-up. And the reason why you see that 73% is because, not because the stump reopened, otherwise it would be a problem, but because the appendage is excised distally, so there is a pouch that some of the surgeons leave that could be prothrombotic, and we really do not have data. We see this in about a third of the patients that have their appendage excised. But at least I think, remember that even if the surgeon closes the appendage, you need to look at follow-up before you discontinue Coumadin, because closing the appendage, especially if it's with ligation and staple, is not a surrogate of permanent closure. Now there are devices, even for the surgeon, that probably would do a better job. This is an example of them. One of them is a clip, a closure that stay there. The only problem that we have seen with this clip is what I mentioned before with the excision, that some of the surgeons do not carefully place this and leave this sort of proximal stump, which can be quite big. And so what is the relevance of this proximal stump is something that we need to learn about. There are other, as I mentioned before, other device, endovascular device that are being used. This is a list of them. Those are the ones that are actually available for clinical use. The Amplatzer is actually already approved in Europe and is undergoing clinical testing in the States, now close to the end of the pivot of the feasibility part of the study, ready to enter the pivotal study. Coirex is close to CE market, should get CE market within the next couple of weeks. And obviously, probably in the next year, you will see this device being tested in the US in FDA IDE. They are, as I mentioned, epicardial system. And everybody, when we talk about epicardial, think about surgery, but they are actually percutaneous device. The two surgical are the atrial and Medtronic. There is one percutaneous, which is the center heart, the lariat. This is a series of less than 100 patients. This is a system that is implanted both endocardially and epicardially. I'll show you an example. And this is this series of 89 patients where that were done exclusively in Poland, where the result looks quite encouraging. However, when many of us use this device in US, we have seen a few issues that I think people need to be aware. This is another small series of 21 patients showing the pre and post, also the CT there, with, again, very promising result, a follow-up. This device is FDA approved on the premises that this is a epicardial, quote-unquote, surgical approach, although, as I mentioned, it's done percutaneously. And this is an example of one of these cases. So what is required? You have to go transeptal, and you have to go epicardial percutaneously. As you see here, you see the wire loop at the pericardial space, and you see a sheet injecting constant endocardially into the appendage. And we create a sort of a railway between with two magnets that touch each other at the tip of the appendage anteriorly, and then over this sort of railway we advance epicardially this snare that you see, the big loop that eventually is suture. The balloon that you see there endocardially mark the ostium of the appendage that is visualized by TE or intracardiac echo. And once you are in place, the suture is tight and is removed. Then you see here that the suture is removed. An angiogram is done, the appendage is closed, and this is verified by TE. However, although this problem was underreported, actually was not reported in the early Poland series and also in the other 21 patients that I showed you before. This is an example of our patient that have a perfect acute results with complete closure, and that at the 1 month EE, the appendage is reopened. You see an opening of about 4 millimeters. The other things that we have seen, if you stop anticoagulation immediately after the implant, is a thrombus that connected to the center of the ligation. So although the company claimed that you can stop Coumadin right away, we, in our practice, continue that until the 1 month follow-up for this problem and for the presence of some cases of clot formation. So issue with this approach, incomplete closure, reopening, thrombus formation at the center of, if you stop Coumadin right away. Certainly there is need for more expertise. And other things that we've seen in a few patients is late effusion, that usually is completely serous effusion, which need to be people need to be aware of. This is a series of 160 patients that DJ put together, Dr. Chiredi put together with us. And I think I want to show you this. So the follow-up TE show that, let me go to this one. Yeah, 86% of the patient at 3 months have a complete occlusion, will remain stable at 12 months, whereas 40% of the patient have a reopening between 1 and 4 millimeters, and those are kept on Coumadin right now. Here you see a more than 5 millimeter reopening 0, although we have one patient now that we just saw a month ago at the 12 months follow-up that had a small leak at 3 months and was completely reopened at 12 months. So I think this is something that tells us that we need to learn, we need to watch these people. But overall, the patient that remain completely closed at 3 months stay completely closed at 12 months. And this is something that I think is reassuring. So I'll stop here. Saying that atrial fibrillation is a frequent cause of stroke, And we now have evidence that most of the time this originated in the left atrial appendage. I think they have proved that. Catheter closure of the left atrial appendage is feasible and safe. A randomized trial with the endovascular device showed that the procedure is safe, effective in stroke reduction and non-inferior when compared to anticoagulation. Currently, 4 devices are available for left atrial appendage closure, but many other are currently under development. Thank you very much.